Hey everybody, how you guys doing? I have a special guest today. I want to introduce who I'm going to talk to just in a moment, Dr. Rebecca Kennedy. And I wanted to give you guys a little backdrop on Rebecca Kennedy. She's a physician here, and I felt really lucky to have a chance to talk to her. She works in this field of mind-body medicine now, an internal medicine practitioner. She's been a family medicine physician for over 20 years. She's had a lifelong interest in the mind body connection and the body's ability to heal itself. And as you're going to learn here, and she'll talk about it, she worked at Kaiser Permanente in Portland, Oregon for about 15 years. And then she started to develop this curiosity to find better ways to help her patients than the current medical model that was failing. And after years of searching, she found this mind body approach to chronic pain and undertook extensive training in the model. She's worked with hundreds of patients in the integrative clinic at Kaiser Permanente using this mind body approach over several years. She also ran the long COVID specialty group for the entire Northwest Kaiser Permanente region, so she'll talk about here. And where she literally assessed hundreds of patients with long COVID, restoring many of them to good health with this mind body approach. And after she really saw this, she witnessed this transformative impact of the model. Dr. Kennedy, she left Kaiser in 2023. She established her own clinic now, and she focuses exclusively on mind body medicine. Her practice is called Resilience Health. There's a link here in the notes if you want to reach out to her. She's based in Portland, Oregon, like I said again. And she also provides virtual consultations for people around the world. And like myself and other people in this space, she's committed to spreading the word about this new science that can really transform people's lives, as you know. So sit back, enjoy this episode today, and we'll see you guys next time. Good to see everybody here today. I have a special guest here today, Dr. Becca Kennedy. Thanks for being here, Becca. How you doing?
Well, I'm doing great. It's fantastic to be here.
Yeah, I really wanted to bring you on because I feel like the more voices that are out there and the more we can share what's happening here just helps people to understand, right, move forward and take action in a new way. So thanks for being here. And yeah, let's jump in. I want to start with just maybe share your background with the audience. So if people don't know who you are and
Yeah.
how you came to do the work you've been doing now.
Yeah. So I'm a family medicine physician. I live in Portland, Oregon, which is where I did my residency. And I've been a physician for, gosh, over 20 years, almost 25 years. And I worked at a migrant farm worker clinic for the first 5 years of my career, doing delivering babies and the whole thing. And then I switched to Kaiser Permanente in primary care, which is very high volume, seeing many patients. So I counted the other day, and I've probably seen over 60,000 patients in my career. And as family medicine, especially at a place like Kaiser, is that we not only see the whole person, but in the Kaiser system, I mean, everything that they've done and all the specialists and of every single department is really all in one place, and it's very comprehensive. So I think it's most easy with the volume that we see and how comprehensive the charting and just the communication is. We really see the whole picture and the patterns. And so actually just a decade into my career, I just didn't understand why we couldn't help so many people. And seeing these patterns over and over and over and over again, and the diagnoses of all these different diagnoses, which I now know are, neuroplastic or kind of mind body diagnoses, often would happen in the same sort of, the same person, more likely. And people also often had mental health diagnoses, but it wasn't that the mental health diagnoses were the cause of the symptoms exactly. They also weren't the result of the symptoms exactly, but they more coexisted. And then also sort of finishing up this triad is people were more likely to have a history of trauma or stress, and just seeing this over and over and over and over, evaluating their body, but yet sending them to mental health wasn't helpful very often. And I think often there's this chasm. I just saw this chasm where I'm like, oh, I checked someone out for their chest pain, for instance. Everything was fine, so I'd send them to mental health. But if they're in mental health and they say, oh, I have this crushing chest pain, that's not their job to say that this isn't, their body said they would send them back. And I just saw people being lost in the middle. So I just searched and searched and searched and searched for the missing pieces because it just didn't make sense to me why we couldn't help so many people. And it's estimated by many studies that it's a good 40% or maybe even 50% of all the primary care visits every day are because of these sort of symptoms. And I was fortunate enough to come upon this work a few years ago.
Yeah. How did you first come up on it? Do you remember what was your first inkling around it?
Well, when so I got interested in just thinking about finding solutions probably about 10 years ago, maybe, when fibromyalgia was much more common as a diagnosis. And so I just searched and searched. And actually, the first place that I ended up was at Harvard at a continuing medical education course at their Mind Body Institute. And I thought, oh my gosh, this is amazing. They've been studying for decades when our nervous system is stuck in fight or flight, what happens biochemically in our body. And I thought, oh my gosh, this is awesome. Took it back to my patients and I said, oh, hey, look, I understand now why you have all these symptoms we can't explain. And they said, great, what do I do about it? And I said, well, meditation, cognitive behavioral therapy, eat well, get sleep, connect socially is essentially what they teach in this program. And they said, yeah, I'm doing all of that and I'm still suffering. And
Right.
I thought, all right, well, I can't tell you to meditate more. So I
Back to the
continued
drawing
my
board. Yeah. Got to go a little deeper
exactly,
in your understanding. Yeah.
exactly. Yeah, right. And not to say that those things aren't helpful and can't help some, or, for some people it helps completely, but not everybody. So I continued, I mean, I just was constantly reading and taking courses and, everything I could possibly get my hands on. And then several years ago, I said to my best friend in medical school, I went to University of Michigan, I just don't understand why we can't help so many people. And she said to me, oh, well, I send my patients to Howard Schubiner with chronic pain and he fixes them. They come back to me and they say, yeah, my pain is gone. And it's so interesting to think about, and I talk to my patients about this a lot, is that experience for me in that moment was a moment of cognitive dissonance. And
Mm.
what cognitive dissonance is when we have two beliefs that we cannot simultaneously hold to be true. And the two beliefs were, well, chronic pain is not fixable. You can't cure chronic pain. And that was my lived experience in, 20 years of a career as a physician and everything that I had learned and heard from the specialists around the country and the world. But yet, this was my best friend from medical school, and it was her own patients. And so
Mm.
I had to let one of these beliefs go. And because it was my best friend and I was searching for this work, I chose to let go of the belief that chronic pain wasn't curable or
Yeah. Just
treatable.
manage
And
it
so,
only. Yeah.
yeah, so in that, I then thought, okay, well, what piece am I missing? Like, how is Howard doing this? And so I searched out Howard and I took every course that I could and really dove into it myself. And then I was working I'd just gotten a little bit of time in the integrative clinic at Kaiser when I learned this. And so I just dove right into it. And again, because it was Kaiser, I was quickly inundated with patients and I was shortly I had like hundreds of patients that I was trying to see in every single corner of every way I could in my clinics.
Mm. Wow. So at the time you were the only one doing this within Kaiser, it sounds like, because you were seeing so many people. Yeah.
Yeah, right, right. Hmm.
So what happened from there? So you were treating people there, um, and then you decided to move on from that position, or what happened at some point?
Well, I really wanted to bring this model to Kaiser because I thought Kaiser is a really great place since it's an HMO and it's integrated care. So I tried as hard as I could to bring the ideas to the leaders in the larger system. I kind of wrote things up. I met with different leaders, talked to all these different people, but I just wasn't able to get them on board. I was able to get them to agree to give me a little bit more clinic time to do this, but as I did this over a year and a year and a half, I also became the lead of the long COVID clinic while I was there. And we would assess all the patients in the whole entire system who were referred by the primary care doctors with long COVID. So I was seeing lots and lots of patients with long COVID and really having success with seeing people improve. And certainly not everybody was on board with these ideas. I mean, this was the front lines that I was on in the Kaiser system of talking about these things. But enough people were, and many people said to me, wow, this is the first thing a doctor said to me that actually makes sense. And so once I saw this, I couldn't unsee it. So I couldn't stop doing it, but I wasn't getting the support and the time that I needed to continue doing this work. And so again, I was really trying very hard to bring these ideas to the system, but I wasn't successful in doing that for a couple of different reasons. And I think one of the reasons was, I mean, I was a little bit more inexperienced with this work. So I don't think I had the right communication or, I'll just say I could have communicated in a better way that I know how to communicate better about it now than I did then. I think also because I was so inundated, I was working with so many different patients. Like, I mean, I was working through lunch and my breaks, and I was just trying to do what I could, but I still could only see people like once a month or even once every couple of months. And I was teaching a class so that I could be more efficient. But I didn't have any patients that were willing to go to the leaders and say, oh my gosh, you know, my life was turned around, even though I was having many patients all the time showing or telling me their success and they were so glad to be doing this. But I didn't have that patient yet that I could talk to the leaders about. Um, and then also, I think it's just such a paradigm shift. It's just so hard to wrap our brains around. And when I would talk to the leaders about this, I think what happens is, and this is just how our brain works as a human, is that we just put these ideas in the bucket that we know, because the idea that we could cure chronic pain and long COVID and IBS, and all of these things is just too big an idea to wrap our brain around. And so I think what they heard was that I was teaching people based stress response, or, kind of these things that they already knew, but what they'd experienced was it actually wasn't that helpful. Like maybe it can help people a little bit, but wasn't that helpful. So just I couldn't get them to really understand the power of what this work was, and really the power of how it could apply in a place like Kaiser. So I decided to leave in 2023 and I started my own practice.
Mm, yeah. Yeah, it's a hard system, isn't it? It's a big system. And when you tried and you did some good work there, but so you started your
Yeah.
own practice and you mentioned COVID, so I want to touch on that a little bit. That I know you've even done some, I think, research in that area. Maybe feel free to share some of that with the audience too about what are some of the findings.
Yeah, for sure. So I haven't done the research myself personally, but I do I have sort of found my one of the niches in this world is long COVID because of my experience of being the lead of long COVID at Kaiser. And we had 600,000 patients in our system, and there's only a few of us that ran the long COVID clinic. So of all of those 500,000 patients, they all got filtered through just a few of us. So when I was at Kaiser, I assessed hundreds of charts of people that had been diagnosed with long COVID. So I really was able to experience a huge breadth of and range of who are the people that have been diagnosed with long COVID. And then my partners ended up actually sending the patients that were the most difficult cases to me, because I used these other approaches. So again, I really had a lot of experience working with people, and also seeing people that were really the most severe of the most severe patients starting to get better and improve with this work. So I have looked, a lot into the research that's out there. And well, actually going back to my clinical days is very early on in 2021, patients would say to me, I have long COVID and that I got after having a COVID infection. And sometimes that COVID infection wasn't very severe. Sometimes it was quite mild. And actually, that's what the research shows is that the vast majority of people who have long COVID are actually healthy people in the middle age, more often women than men. It's actually not elderly sick people
Mm.
that predominantly have long COVID. It's also not the people that have had the very, very severe COVID infection in the hospital, which again just doesn't make sense if we think about it through the lens of damage in the body. But patients also said to me, I actually never had COVID. I got long COVID after having the vaccine. And this was back in 2021 when there were actually people who hadn't actually had the COVID infection yet.
Yeah.
And sometimes they got the symptoms minutes after having the vaccine. But sometimes they actually did fine after the vaccine, and it was months later that they developed the symptoms. And again, physiologically, that is just not how our body works. There's no way that a vaccine can cause symptoms within minutes that last for years. It just doesn't work like that. It also doesn't work like we can be fine for months and then develop symptoms that now we're blaming on the vaccine. Again, physiologically, it's just not how our body works. But the more interesting thing is that I had patients that said to me, oh, I neither had the COVID vaccine nor or I didn't have COVID infection nor the vaccine. These are the same symptoms I had prior to the pandemic even starting, but now they're much worse and they're the same symptoms of long COVID.
Mm.
So very early on, clinically, my experience was that you could have long COVID and the pattern of symptoms of long COVID, but not actually even have had COVID nor the vaccine, which is again also what research is showing.
Yeah.
So
Yeah.
the other parts of research are you know large research studies of hundreds of thousands of patients showing that you're predisposed to getting long COVID by having had a history of anxiety or depression or PTSD or having psychological stress. And that's what huge studies are showing. There's a study out of by Daniel Klaw out of the University of Michigan. They looked at 3 million charts and found that people who had a history of chronic overlapping pain conditions like fibromyalgia or chronic pain or chronic fatigue were 40 to 50% more likely to get long COVID after having a COVID infection, but also more likely to get long COVID after just having the flu, and sometimes not even having either of them.
Yeah.
So,
Powerful, powerful data. I know the more and more data coming out around this. It's really good to see it. I guess it's one of the silver linings we could take from COVID, right? Is more of this
yeah.
research coming out. So you kind of work with a lot of people with COVID. What type of conditions do you see in your practice now? I'm sure you see a range of different diagnoses or conditions.
Yeah. Yeah. Well, certainly, especially since I'm a family medicine doctor, I mean, I really see anything and everything. So, certainly a lot of people with long COVID, um, but anything from chronic migraines, headaches, chronic pain, chronic back pain, GI dysfunction, people that aren't able to swallow and eat, itching, chronic itching with no rash and no, other cause seen, anxiety, depression, insomnia, um, just really anything and everything.
Yeah. So at this point, you specialize in this work, right? So if someone comes in to see you, you're going to take a full, right, a different lens of how you see this person. Maybe share with the audience a bit of what you're looking for when you are assessing somebody for like a neuroplastic symptom.
So my new correction. So the clinic that I started, I only work with people with these chronic neuroplastic symptoms. I don't do primary care anymore. But when someone comes in, as a physician and, as the patient, we need to make the right diagnosis in order to treat them appropriately. So if someone has a sore throat, we need to know, is it a virus? Is it strep? Should we use an antibiotic? Is it a sore and it's going to heal over time? What's the reason for it so that we can treat it appropriately? And I think a lot of people don't realize that what we are taught in medical school is that 80 to 85% of how we make a diagnosis is based on history alone. The pattern of the symptoms is really profound of how we decide what the diagnosis is. And we don't necessarily get there 100% all of the time just on history, but that is the vast majority of it. And then we look at the exam, what other pieces of information add to it based on the exam, and then we do testing. And the testing is largely to either confirm what we already think might be going on, or we're ruling out to just make sure that there isn't, something else going on. And I think what I found is that a lot of people think that you must have a test in order to diagnose something. And the reason why the pattern makes such a big difference is that when we understand how the body works physiologically, based on the pattern alone, we can rule out what's happening. So, for instance, if someone has weakness in their hand, but they can move their arm just fine, we know 100% it's not a stroke. And we don't need to be doing a CAT scan or an MRI of their brain, because a stroke would cause damage in the nerve from the brain, so it would affect that nerve all the way down through the arm to the hand. So that can't possibly be where the problem is, because they can move their arm. So now we're going to think about peripheral nerve, and then we're going to go from there. And then we're going to look, well, is it red and swollen? Well, if it's not red and swollen, then well, it's not an infection. So again, there's so much power in the pattern. And then the other part is that I think also a lot of people think that specialists and scientists are the ones that really know the answers and the information. When it is about a very, very specialized case, yeah, that is the case. Like, as a family medicine doctor, I'm gonna send my patients with, some heart condition that's not so common to a cardiologist. But the difference about a primary care physician is that, again, over these, tens and tens and tens of thousands of patients that I've seen, we see the whole person. So we see the whole pattern, and we know over time the different diagnoses that they had. So last year they had migraines, maybe their migraines got better, but now a year later, 2 years later, now they have IBS. Or now the pandemic started and now they have long COVID. And a primary care doctor is really the one that brings all of these pieces together of all the different parts of our body, as well as the history, childhood, the stresses, all of the pieces of it. So when we look at someone and deciding what the diagnosis is, we take all of those pieces into account, and we look at the pattern of their symptoms, what makes sense, and we do the workup. And it is absolutely critical that someone have a whole, full, thorough workup. We need to make sure that we're making the right diagnosis, right? That we're not missing anything. So absolutely, that is really critical. But that workup often is not as difficult as someone might think. And really going to a regular doctor, primary care doctor, is really, all that needs to be done for the most part with that. But then we also look at the other factors. What's going on in someone's life, what stress was happening in their life, or what changes was happening. Sometimes I'm sure Jim, sometimes it's not actually something that we would perceive as a stressful time in our life, but still the life events still can be rolling into how our brain's responding. What did we go through prior in our life? It's putting together all those pieces. But all of that often isn't quite enough yet. So then we really, really look in a very detailed way at the pattern of the symptoms. We need to know for sure, is this due to structural damage in the body as the generator of the symptoms, or is it because the neural circuit was created and stuck in place? And was that neural circuit created in the first place because of our psychological stressors, because our brain perceiving danger for whatever reason, or is it because of structural damage? And we look at Dr. Schubner's FIT criteria, looking at the function, the inconsistency, the triggers. So if the symptoms are inconsistent, like if they come and go, if they shift around and they move, if I used to see people in primary care and sometimes they would come in and say, I have pain that's all on the right side of my body. The right side of my body throughout my life. It just hasn't been that's always where the problem is. Well,
Mhm.
again, there's nothing physiologic at all where things are just going to happen structurally all on the right side of the body. So it's looking at the pattern physiologically, or is it a little bit better some days and worse other days? Or is it triggered by things that aren't actually causing damage in our body? Is it triggered by something outside of our body, like a computer screen causing a migraine? And it's so funny. It's these things that we just are taught and we just take for granted. Well, of course, lights from a computer screen cause a migraine, right? That's what I spent my whole life thinking and experiencing, and not really stepping back and really thinking about, well, it's just light. Like, what damage could that possibly be doing inside of our body that our brain would then be responding to? But if someone's at work and it's stressful at work and they're looking at the computer screen all day long, well, now our brain, because of a conditioned learned response and learning to associate these different pieces of information coming in at us, well, now our brain can learn to associate stress and danger with the light of a computer screen. And then, because our brain is always scanning the world for danger, trying to keep us safe, well, now maybe we watch a funny movie at night, we're relaxing, but our primitive brain says, "Oh, a bright light, I know that means danger." And then it puts in, because of prediction and expectation, that warning signal of the migraine. Maybe it does that because of walking outside and there's the sun. Well, that's a bright light. And
Right.
so really looking at all of the pieces of information to really make sense of what is the generator of it.
Yeah, and a lot, I'm just listening to this, it's all great information. Just highlighting how much of this is unconscious too, right? I think people don't consciously maybe even know, right? Maybe speak to that, like these sensitization reactions, or that they're stressed even, because a lot of times we don't know, or that maybe it's emotions coming up. So maybe speak to that a lot of this can be unconscious.
Yeah, oh my gosh. Well, number one, all of it is unconscious
Yeah.
that tells our body what to do, right? I often say to people, make your intestinal muscle move right now, right? Like, we can't do it. The only part that our conscious brain can control in our body is our skeletal muscles, which is the muscle that's on our skeleton. We can make our arm raise up through a thought, but we can't change anything else inside of our body. And so it's our unconscious brain that is the part of our brain where the danger center is located. So it's our unconscious primitive part of our brain that's deciding if a piece of information coming in at us means danger, or if it means safety. And that's actually, frankly, all our unconscious brain cares about. It just cares about staying alive on the planet. Doesn't even care about enjoying our life on this planet. It
Survival
just cares.
brain, not thriving brain.
Yeah,
Yeah.
right, exactly. So, and what I learned in doing this work, actually, I wasn't taught this in medical school, that only about 5% of our brain is our conscious thinking rational brain. A whole full 95% of our brain is the whole rest of our brain. That's the unconscious part of our brain that's constantly telling our body what to do, like nanosecond by nanosecond, constantly updating and sending biochemical messages that tells every single part of our body what to do, our heart how to beat, our digestion how to digest. the little muscles on the insides of our blood vessels, if they should open up or if they should close down, what our hormonal cycles are doing. I mean, literally every single part, the functioning of our body is happening at all times because of what our unconscious brain is telling it to do. And so when our unconscious brain is perceiving stress or danger, it's sending these messages away from our conscious awareness. And what our unconscious brain perceives as stress is actually not necessarily what our conscious brain perceives as stress. And I think that can be the big sort of aha moment for people is, and I used to say to people before I knew about this work, I would often say, well, because their symptoms made sense that it was stress, and I would say, well, how's the stress in your life? And people would say often, oh, I don't know, I'm not stressed right now. And at first, I think I would just sort of believe them and say, oh, okay, all right, well, it's not that then. And then I think I started to push more a little bit. And I said, okay, well, tell me about your life. And there was a lot of times people would say, yeah, I'm not stressed. I mean, I have 3 kids and I went back to school and I'm working 3 jobs and I am taking care of my sick mother. But I mean, I don't feel stressed.
Right.
Um,
So common, right?
so,
And it is such a, like you said, you
no.
can be in opposition to the conscious and the unconscious, and right, even emotions, right, are produced by the unconscious brain. And maybe you can speak to this too, how a lot of times they can come out physically in the body, and
Mhm,
we don't even know we're having an emotion. We just, oh, I got a back pain, oh, I got a headache.
mhm,
Maybe speak about a
mhm.
bit about emotions too.
So when I learned this work, so when I found, Dr. Schubiner, and I was like, okay, well, what do you do? Like, what is this? And so I first started learning about it, and it just like, I mean, I just felt like I actually had like an out of body experience because it just was so different. And so I sort of learned the part, okay, we need to break the fear symptom loop, kind of somatic tracking, calming our nervous system, meditation, breathing, these different things. And so I had also learned that repressed emotions could be a part of this. And if someone had told me that aliens just landed in my backyard, I literally would have believed that over repressed emotions could be a part of chronic pain. I mean, I just was like, what? I mean, it just was like the craziest thing in the world. So when I first started doing this work with patients, I really focused on these other parts, the somatic tracking, the, breathing, meditation, mindfulness, all those stuff, kind of, showing people the science, their body's not broken, it's not brain. And it helped, but there was many people that didn't get there enough. And so I thought, all right, well, I'm going to start looking into these, this emotion business more. And what I found was that for a lot of people, although not everybody, repressed emotions can indeed be the driver of what the unconscious brain is perceiving as the threat. And I talk a lot about it with my patients is that, as a survival brain, and we come into this world, all we care about is survival. And we need our parents in order to take care of us so we don't die. And we need to get our parents' love in order to get them to take care of us so we don't die. So if our parents treat us in a way that we don't deserve, well, if we're treated disrespectfully, our self-agency is standing up for ourselves. Anger is the appropriate emotion for that. And the emotions are created automatically from our unconscious brain in order to protect us. But if standing up for ourselves, fighting for ourselves, is going against our lifeline, our parent, while expressing that anger is not an option. But
Yeah.
the emotions are made automatically, actually, as a survival protective mechanism. And so the emotion is still made, but in order to keep us safe, our brain represses it into the subconscious. And as a child, that can often happen that anxiety or depression or guilt or shame is actually misdirected anger because being weak or small or the victim going to sadness and tears, that is safer for our unconscious brain than standing up and fighting
Yeah.
our lifeline. And So tears, I also have learned in this, can be a protective mechanism that actually stops us from feeling and expressing the appropriate emotion of anger often. I spent my whole entire life going to tears. Like I couldn't actually stand up for myself if I wanted to because I would just start crying and then I couldn't even talk. And actually, once I learned this work and, how to express my emotions and stand up for myself in a healthy way, that doesn't happen really anymore.
Yeah.
But then if we also get taught other information that expressing emotions is not safe, if we learn that from our parents, maybe they express anger in an unsafe way, it feels scary, or maybe our sibling does, or maybe our parents just don't teach us that our emotions are not okay, or our culture and our society, because of sexism and racism and bigotry and all these different things, a marginalized group are taught that it's not safe to express our emotions. So there's lots and lots and lots of different reasons that our brain learns that it's not safe to express the emotions. And so when that happens, it dials up the danger part of our brain. And when the danger part of our brain is dialed up, it creates a symptom in our body in order to communicate with our conscious brain that there's danger there. And that symptom can be anything. It can be very specific. It can be pain in our back, or it can be anxiety, or it can be our GI system getting shut down, or it can be depression, or, lots of different signals.
Yeah. That's beautiful. Really well said. And how these emotions, and you're really highlighting how anger is one of the core emotions that does get repressed and suppressed or sandwiched between these other emotions, and how I noticed that too in people where people would go to tears and that's the only emotion they would go to. And I would say that's a common thing. So on occasion, I'd see some people where the opposite, where they would just go to anger and they wouldn't go
Mhm.
to tears or grief or
Yeah,
sadness. But like you
yeah,
said, it can be variable. But
yeah,
but yeah, the power
yeah.
of these emotions, right? That and some people don't realize they're disconnected from their emotions. They're just getting the symptom. And so,
Mhm.
yeah, how would you
Yeah,
maybe share, how do you work with people with these emotions? What kind of process do you
yeah.
do?
All of that's so important. And I think that more often, although not always, women are more often cover up the anger with sadness and tears because that's a safer emotion. More often, although not always, men can often cover up the hurt, like deep, deep hurt and sadness with anger. And oh, actually, when I learned about the tears being a protective mechanism, even just like a couple days later, tears came up for me, and I stopped myself and I thought, all right, what thought just went through my brain? And what the thought was, I mean, I don't remember exactly what it was, but it was something about me being disrespected. And it was such an aha moment. I thought, oh my gosh, tears is not the appropriate emotion response to this right now. It's actually anger. And so I sort of stopped myself and I kind of brought myself over to allowing myself to feel angry about the situation. And so those are the sort of things I do with patients is I mean, number one, go through their history and what their brain learned growing up and what makes sense for the current situation of what the response is and what the appropriate emotional response is. And so, and I work with patients doing the emotional awareness and expression therapy. So the exercise of how to express emotions sort of in this healthy, safe way and really connecting in on our own inner love and compassion, kind of understanding for humanity so that we can let go of these emotions. Um, and and really having people look at the situations that are happening in their life. And sometimes it can be helpful to look at that through the lens of someone else they care about, because often it's harder for our own brain to go to our emotions for ourselves if we've experienced a whole lifetime of repressing them. It's easier to bring up those emotions when we're thinking about someone else we love. So sometimes I guide people to um, express or kind of work with their emotions around someone else, a different situation before kind of coming into themselves.
Yeah, because I know Dr. David Clark talks a lot about that by putting yourself in someone else's shoes and witnessing it. Because again, the repression and suppression, repression is unconscious, right? So a lot of times again, we're not aware. And sometimes I'll give people the simple multiple choice to start with if they're really disconnected. Say, okay, let's play the multiple choice game. Let's take four primary emotions. Okay, do you feel happy that this happened? Okay, let's check that one off. Do you feel sad? And then we can kind of go through because some people
Yeah,
really are disconnected pretty strongly,
yeah,
not their fault,
yeah,
right? So trying to get them back to these emotions. I find, like you said, it's alien. It is hard, right, to even believe that, and then it's even hard to connect to the emotions because we don't feel them. So it's a very interesting area, I think,
yeah,
emotions.
totally. Oh my gosh, I love that multiple choice. I'm going to use that. And that's the thing is that I think that's what's so hard about this is that they're repressed unconsciously. So by nature of what that means is that we are not consciously aware. And so people say to me all the time, yeah, but I'm not an angry person. Yeah, but I'm not angry. That's not who I am. Yeah, right, exactly. And really it's connecting up with that we can only experience love by also having anger on the other side. So really showing people that because they're such a deeply, deeply compassionate, loving person, that's actually why they have the anger. And that it's not a bad thing. And anger doesn't equate with violence. And anger is just for ourself and expressing by ourself. And then healthy communication and boundary setting is really important if we're not being treated respectfully. But the expression of the emotion is just something that we can do by ourselves.
Yeah, yeah, it's great. What would you say about, because I know there's different, right? We could talk about reducing fear, somatic tracking. We could talk about changing someone's belief, right? Believing they're okay. Then we could talk about emotions. Have you thought about more like the breakdown of that, like in the people you see, like how many people you feel like are the repressors, suppressors, and how many of them can get better just through fear reduction or belief alone? What have you seen in your clinical practice?
Oh gosh, I just think about these things constantly, and I'm always just so endlessly curious to build and grow and expand, sort of the ideas and what works, what's going to work for some people and not others. I think it's really interesting that so much is like part of what is so key is really fully stepping into that we are not broken and really starting to see ourselves through that lens. I think it's just so key and it's not easy. Um, and that part's really key. And looking at that evidence, really gathering that evidence to look at that is really important. I think that also I've started um, I've started shifting over a little bit more to really thinking about, this is learned neural circuits and not to feel bad about it. We don't have to blame ourselves, but our brain just practice this and practice and practice, and it's the default automatic mode. And so it's shifting into what new neural circuits do we want to create for ourselves and really bringing that in through love and positive emotions and showing our brain the roadmap of where we want it to go and practicing that. And I think that that can be really important and really helpful. But I have seen that often we do need to attend, many people do need to attend to more understanding and learning self-compassion and self-love. And when our brain didn't learn that as a child, I think really going back and rewriting those memories through the emotional work, and really getting to the understanding of that so that we can kind of step into these other pieces.
Hmm.
And what I found is that I think I've experienced with, some patients, I think that part is a lot more important and really diving down into that can be really key in order to be able to really get into that self-love and self-compassion so that they can really go forward. And then some people don't need it at all. And then some people do need it, but it it doesn't take so much time. They can kind of go back into that and really understand what happened in their past to get them to where they are now. But in doing that, they can work through it much quicker.
Hmm. Yeah. Yeah, it's a great answer. There's so many facets here, right, and pieces to it. I don't think there's right one answer for each person, right? So it's based on the person's situation, their history, right? But it's really fascinating. I think the field is right evolving in a lot of ways from where it started out from Dr. Sarno, and it is
Yeah,
interesting to talk about these different areas and see how people can recover in different ways, right?
right,
Yeah,
right.
so what are you excited about in this field? What are you seeing now that you've been working in this for a while? I know you're doing some teaching. Where do you think we're going with some of this stuff?
Well, gosh, I mean, I am super excited about this field just in general. Clearly, it seems to me like I went to the SERPA conference in London just a few weeks ago, and just the energy and the excitement there in Europe, and then to be back here in the States and just see these different places in the world where the energy and the excitement just seems to be really bubbling at the surface. And um, it seems to me like I think it's very close to really kind of breaking through into the mainstream. And for me, I'm just always thinking about how can we bring these voices together and give this powerful message? Because I see patients every day. I mean, probably get, 4 or 5 calls every week of people really suffering from long COVID or chronic fatigue, don't know about this work, or, maybe they know some, but not completely. And gosh, I'm sure, Jim, that you experienced this, maybe not about long COVID per se, but, maybe different chronic pain, but, a new patient will come in and really, really resist the ideas and just say, oh my gosh, but how could that be? But no, I have structural damage in my body, but all these specialists, all, the Mayo Clinic, all these different places say different information that there's damage in my body. How could this be? And really, really resist it. And, under the scenes, kind of behind the scenes, just seeing hundreds and thousands of people really who have gotten better and are on board. And it's just so clear and really bringing this information up more to the surface and really for everyone to experience and really know that this information and really get it into our life, that people start learning about this in medical schools and high schools, and that this just now becomes the regular information that they believe.
Yeah, that's my hope too, and it's very well said. Well, I know we could probably talk for hours on this. How can people find you if they want to reach out? Are you do work through online as well, right? Through Zoom, and maybe share a bit about your practice if people want to reach out to you.
Yeah, so I see people over Zoom all around the world, and my practice is called Resilience Healthcare, although I'm having a little bit of a shift. It'll be called Resilience Health soon. My website right now is resilience-healthcare .com, and it actually is going to be changing, and I'm sure it'll take people there, but it'll be resiliencehealth.io in a few months. And the reason for this shift is I have a new team that I'm really excited about. Some really fantastic women doing the same exact work. A couple of them are in Portland with me, a naturopath who works with this exact model of the brain and the nervous system and neuroplasticity, a coach, Isabel, and then a physical therapist, Nita, as well. So, and we've been starting to see people all together as a team. That's been really fantastic.
That's great. Yeah, that's that teamwork again, but in a different model, right? Versus the traditional chronic pain teamwork,
Yeah,
right? Which just must be
yeah,
really nice. Yeah, I'll put
yeah.
your information on the channel so they can access the link to your work. And Yeah, thank you so much for coming on. This is really enlightening and listening and hearing. I love to talk to people about this and being a doctor, right? It's really great to see you're doing this work now and contributing to the field. So thanks for being here today.
Yeah. Oh, well, I appreciate it. And I've so many patients have worked with you and know you and just have such great things to say, and you've helped so many people. So it's really great to connect up.
Yeah.